In this lecture, I'm going to talk about mitral stenosis, and I'm going to present clinical cases related to the subject, as well as multiple choice questions as interactive tool to emphasize important points. Case 1, a 79-year-old woman has worsening shortness of breath for several years. She now has to sleep sitting up on two pillows. She has difficult swallowing. There is no history of chest pain. She's afebrile. Recently, she suffered a stroke with left-sided hemiparesis. A chest X-ray reveals a normal left ventricular size with a prominent left atrial border. Which of the following conditions is most likely to account for these findings? Aortic coarctation, dilated cardiomyopathy, essential hypertension, left renal artery stenosis, mitral valve stenosis. The correct answer is mitral valve stenosis. Aortic coarctation and left renal artery stenosis are causes of secondary hypertension. Essential or secondary hypertension cannot explain the findings in this case. Dilated cardiomyopathy can cause progressive shortness of breath as a result of left-sided failure, but as its name entails, dilated cardiomyopathy is associated with a dilated left ventricle. So why is the correct answer mitral stenosis? Mitral valve stenosis leads to left atrial enlargement, but the left ventricle is usually small. Mitral stenosis can result in progressive worsening of shortness of breath with progress of the disease. Long-standing mitral stenosis can result in atrial fibrillation as a result of progressive left atrial enlargement. AF can be associated with thromboembolic events, and this explains the stroke the patient in this case has developed. As a matter of fact, the risk of thromboembolism in patients with mitral stenosis in association with atrial fibrillation is 17-fold the risk in controls. And that's why patients with atrial fibrillation and mitral stenosis should receive lifelong anticoagulation. An enlarged left atrium may lead to pressure posteriorly on the esophagus, leading to dysphagia. And this explains again the difficult swallowing the patient in this case is suffering from. As you can see in the lateral chest X-ray, the enlarged left atrium indents the barium-filled esophagus posteriorly, and so the esophagus is pressed upon and causes dysphagia. Let's now revise the anatomy of the mitral valve. The mitral valve consists of an anterior leaflet and a posterior one. The anterior mitral leaflet is divided into three scallops or three segments, A1, A2, and A3, while the posterior leaflet consists of three scallops or three segments, P1, P2, and P3. Scallop 1 is the most lateral, while scallop 3 is the most medial. The normal mitral valve orifice is between 4 and 6 centimeters squares. The severity of mitral stenosis is defined by the orifice area of the valve. The patient usually becomes symptomatic when the mitral valve orifice area is reduced to below 2.5 centimeters square. A mitral valve area between 1.5 and 2.5 centimeters square is considered mild to moderate mitral stenosis. Patients with mild to moderate mitral stenosis usually have dyspnea precipitated by moderate to severe exertion. A valve area between 1 and 1.5 centimeters square is considered severe mitral stenosis. patients with severe mitral stenosis may develop exertional pulmonary edema. A mitral valve area below 1 centimeter square is considered very severe or critical mitral stenosis. These patients usually have dyspnea at rest, they are orthopnic, and they may develop paroxysmal nocturnal dyspnea, and so they are considered New York Heart Association classification dyspnea class 4. Another multiple choice question: which of the following is false regarding the pathophysiology of mitral stenosis? Increased left atrial and pulmonary venous pressure, transudation of fluids into the pulmonary interstitial space, decreased pulmonary compliance, pulmonary hypertension, left ventricle is never affected. The correct answer is left ventricle is never affected. Let us now revise the pathophysiology of mitral valve stenosis. As a result of mitral valve stenosis, there is decreased left ventricular filling or decreased left ventricular preload, and this results in a depressed left ventricular ejection fraction in up to 25% of patients with mitral stenosis. Decreased left ventricular filling is associated with increased left atrial pressure and volume, and this results in a stronger atrial contraction or atrial kick, causing the patient to have palpitation. Increased left atrial pressure is transmitted to the pulmonary vasculature, resulting in pulmonary congestion. The passive increase in pulmonary venous pressure may elevate the pulmonary vascular resistance, and this will result in reactive pulmonary hypertension. This condition is usually reversible if the stenosis is relieved. However, in long-standing severe mitral stenosis, obliterative changes in pulmonary vasculature may occur, and this results in obliterative pulmonary hypertension. As a result of the pulmonary hypertension, pulmonary apoplexy due to rupture of dilated pulmonary bronchial veins may occur, and the patient may complain of hemoptysis. Increased pulmonary venous pressure results also in transudation of fluid into pulmonary interstitial space, and this results in decreased pulmonary compliance, so increasing the work of breathing, and that's why the patients with mitral stenosis will have progressive dyspnea. So if we look back to the question once more, we find that the correct answer is answer number 5. The left ventricle is never affected, because this is truly the false statement. As a matter of fact, and as I have mentioned before, in up to 25% of patients with mitral stenosis, there is a depressed left ventricular ejection fraction as a result of the decreased left ventricular filling or decreased left ventricular preload. Decreased filling ultimately manifests as muscle atrophy, abnormal pattern of left ventricular contraction. The left ventricle as well may be affected by myocardial fibrosis or scarring of the subvalvular apparatus secondary to rheumatic myocarditis. Another question: which of the following is the commonest cause of mitral stenosis? Rheumatic, congenital, drugs as mesocergite, carcinoid syndrome, amyloidosis and fibroelastosis, mitral annular calcification, rheumatoid arthritis and systemic lupus erythematosus. The correct answer is rheumatic. Let us now mention the different causes of mitral stenosis. Rheumatic fever is responsible for the great majority of cases of mitral valve stenosis. Pure or predominant mitral stenosis occurs in approximately 40% of all patients with rheumatic heart disease. 2/3 of all patients with mitral stenosis are female. Other rare causes of mitral stenosis include congenital parachute mitral valve, in which shortened chorda tendini insert into a single papillary muscle, causing obstruction to flow, mucopolysaccharidosis, drugs like mesisergide, which was previously used to treat cluster migraine headache, a malignant carcinoid syndrome, amyloidosis and fibroelastosis. Mitral annular calcification can result in degenerative calcific mitral stenosis in elderly population. Other rare causes include rheumatoid arthritis, systemic lupus, prostatic malfunction, infective endocarditis with large vegetation causing obstruction to flow through the mitral valve, and finally Lüttenbacher syndrome, which consists of atrial septal defect in addition to mitral stenosis of rheumatic origin. Now another question: which of the following may be a presenting symptom of mitral stenosis? Left or right-sided heart failure manifestations, hemoptysis, palpitation, cerebrovascular stroke, dysphagia and hoarseness of voice, all of the above. The correct answer is all of the above. Let us now revise the symptoms of mitral valve stenosis. Symptoms include easy fatigability and syncope as a result of decreased cardiac output. Again, the increased left atrial pressure is reflected back to the pulmonary vasculature, resulting in pulmonary congestion, dyspnea, orthopnea, and even pulmonary edema. As I have mentioned before, rupture of dilated bronchial vein may result in hemoptysis. Left atrial enlargement, if it is significant, may lead to compression of the left recurrent laryngeal nerve, and this will result in hoarseness of voice or Ortner's syndrome. Again, the left atrial enlargement may result in atrial fibrillation, especially in elderly patients with long-standing left atrial enlargement as a result of long-standing mitral stenosis. Pulmonary arterial hypertension may lead to right ventricular hypertrophy and eventually right ventricular failure, which may manifest by chest pain, ascites, and edema. Causes of death in mitral valve stenosis patients includes congestive heart failure, systemic embolism, pulmonary embolism, and finally infection. Another question: which of the following is false regarding the clinical feature of mitral stenosis? Apex is not displaced and tapping in character. Apex is shifted outwards and downwards and sustained. There is parasternal heave and parasternal thrill. Accentuated first heart sound. Opening snap. Apical diastolic rumbling murmur. Pansystolic murmur at left lower sternal border, which increases with inspiration. The correct answer is apex shifted outwards and downwards and sustained. because in mitral stenosis the apex is not shifted because there is no left ventricular enlargement. Let us now describe the clinical features of mitral stenosis. By inspection and palpation, the apex is usually not displaced. It is in its normal position, the fifth space left intercostal fifth space mid-clavicular line. It is tapping or slapping in character as a result of the palpable tapping first heart sound. By auscultation, there is a loud first heart sound caused partly by the rapidity with which left ventricular pressure rises at the time of mitral valve closure, as well as by the wide closing excursion of the leaflet secondary to the underfilled left ventricle. An opening snap may be heard after the second heart sound, denoting a pliable mitral valve, and is caused by sudden tensing of the valve leaflets after the valve cusps have completed their opening excursion. A mid-diastolic rumbling murmur localized to the apex is best heard with the patient put in the left lateral position and by the use of the bell of the stethoscope. A presystolic accentuation may be also heard in cases of sinus rhythm. On the other hand, in patients with atrial fibrillation, the presystolic accentuation of the murmur is not heard because of loss of the atrial kick. In case of pulmonary hypertension and right-sided heart failure, left parasternal uplift and epigastric pulsation felt by the fingertips as a result of right ventricular enlargement. A palpable pulmonary component of the second heart sound or diastolic shock may be felt in the left second intercostal space. The pulmonary component of the second heart sound may be accentuated. A pansystolic murmur, which increases by inspiration, may be heard at the left lower sternal border or the tricuspid area. A short early diastolic murmur of pulmonary regurg may be heard over the pulmonary area and may radiate to the left lower sternal border and increases with inspiration. In patients with severe mitral valve stenosis and pulmonary hypertension, may have a malar flush characterized by pinkish purple patches on the cheeks and is due to the combination of low cardiac output and venous congestion. Patients with severe mitral stenosis and pulmonary hypertension may have also raised jugular venous pressure with a prominent A waves in patients with pulmonary hypertension and sinus rhythm. Now a new question. A 42-year-old male admitted with dyspnea is noted to have a murmur suggestive of mitral valve stenosis, the presence of which of the following clinical signs suggests that the mitral valve is mobile: a soft first heart sound, a third heart sound, a fourth heart sound, loud second heart sound, opening snap. The correct answer is the presence of an opening snap. Let me remind you once more of the auscultatory findings of mitral stenosis, which include a loud first heart sound, an opening snap heard after the second heart sound, a loud pulmonary component of the second heart sound in presence of pulmonary hypertension, a mid-diastolic rumbling murmur with a pre-systolic accentuation in patients with sinus rhythm. Riptitic, 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 riptitic. Calcification of the valve results in immobility and loss of the opening snap, which I told you before that it is caused by sudden tensing of the valve leaflets after the valve casts have completed their opening excursion. Now, case number 2, a 45-year-old female with dyspnea, New York Heart Association functional class 4. The pulse is 110 beats per minute, irregular, low volume. The blood pressure is 90/60. There is raised jugular venous pressure with systolic V waves. There is a malar flush and lower limb edema. Cardiac inspection and palpation revealed that the apex is shifted outwards and tapping. There is parasternal heave and parasternal thrill. Cardiac auscultation revealed a loud first heart sound, a loud pulmonary component of the second heart sound, an opening snap very close to the second heart sound. A long mid-diastolic murmur heard at the apex, a pansystolic murmur that increases with inspiration is heard at the left lower sternal border. There is a short early diastolic murmur over the pulmonary area, increasing with inspiration and radiating to the left lower sternal border. Chest auscultation revealed bilateral basal rales or crepitations. The diagnosis of this case is mild mitral stenosis, moderate mitral stenosis, or severe mitral stenosis. The correct answer is severe mitral stenosis. Now, what are the clinical markers of severe mitral stenosis? First of all, there is an early opening snap. The shorter the time interval between the opening snap and the aortic component of the second heart sound, the more severe is the mitral valve stenosis. And this is because of the high left atrial pressure in severe mitral stenosis causing earlier opening of the mitral valve. Increasing length of the murmur is another marker of severe mitral stenosis. Signs of pulmonary hypertension also indicates severe mitral stenosis. Signs of pulmonary congestion, as in this case, the presence of bilateral basal lung crepitations, indicates severe mitral stenosis. A Graham-Steele murmur or early diastolic murmur of pulmonary regurg heard over the pulmonary area indicates severe pulmonary hypertension secondary to severe mitral stenosis. A low pulse pressure as a result of significant low cardiac output is another indication of severe mitral stenosis. This diagram shows the auscultatory findings in different grades of mitral stenosis. In mild mitral stenosis, the murmur is short and the time interval between second heart sound and opening snap is big. In moderate mitral stenosis, the murmur gets lengthier and the opening snap becomes closer to the second heart sound. In severe mitral stenosis, the murmur is louder and lengthier and the opening snap is more and more closer to the second heart sound. In severe mitral stenosis with pulmonary hypertension, the pulmonary component of the second heart sound is loud, the opening snap is very close to the second heart sound, and the murmur is very long, mid-diastolic with pre-systolic accentuation. In mitral stenosis with a rigid valve, the opening snap is no more heard. A new question. All of the following are conditions simulating mitral stenosis except left atrial myxoma, core triatriatum, ball valve thrombus of the left atrium, diastolic flow murmurs across normal mitral valve as in ventricular septal defect, patent ductus arteriosus, severe mitral regurg, hypertrophic obstructive cardiomyopathy, Kerry-Coombs murmur of mitral valvulitis, tricuspid stenosis, and Austin-Flint murmur. The correct answer is hypertrophic obstructive cardiomyopathy, which produces a systolic murmur and not a diastolic murmur. Left atrial myxoma and ball valve thrombus of the left atrium, by obstructing the flow across the mitral valve, produce a diastolic murmur mimicking mitral stenosis. Core triatriatum is a rare congenital defect in which the left atrium is divided by a thin membrane, resulting in 3 atrial chambers, 1 on the right side and 2 on the left side, and hence the name core triatriatum. The turbulent flow across the ostium of this membrane can cause a diastolic murmur. Excessive flow across the mitral valve caused by a ventricular septal defect, patent ductus arteriosus, or severe mitral regurg can also result in a diastolic murmur as a result of relative mitral valve stenosis. An inflamed edematous valve leaflet as a result of mitral rheumatic valvulitis can cause a diastolic murmur or Kerry-Coombs murmur that disappears when the inflammation is relieved. Tricuspid stenosis can result in a diastolic murmur over the tricuspid area that increases with inspiration. Austin-Flint murmur occurs in severe aortic regurg and is due to the vibration of the anterior leaflet of the mitral valve as it is buffeted simultaneously by the blood jets from the left atrium as well as the regurgitant jets from the aortic valve. Another question. Which of the following is true regarding mitral valve stenosis? Doppler ultrasound is usually inaccurate in determining severity of mitral stenosis. In atrial fibrillation, the opening step disappears. Mitral stenosis is well tolerated in pregnancy. The opening snap is not heard when the mitral valve is heavily calcified. There is characteristically a low wedge pressure. The correct answer is the opening snap is not heard when the mitral valve is heavily calcified. All the other statements are false. As a matter of fact, Doppler echocardiography is accurate in determining mitral valve area and consequently it is accurate in grading severity of mitral valve stenosis. In atrial fibrillation, the opening snap does not disappear. In particular, mitral stenosis is poorly tolerated in pregnancy due to volume overload, especially in the second and third trimester of pregnancy. The opening snap is characteristically lost with heavy valve calcification. Pulmonary wedge pressure, which reflects left atrial pressure, is high and not low in mitral stenosis. Another question. All of the following features are present in the following chest X-ray of patients with mitral stenosis except this bulge of the waist of the heart, elevation of the left main stem bronchus, and double density sign. Esophagus is pushed or curved backward by the enlarged left atrium. There is evidence of mitral calcification. there is evidence of pulmonary vascular congestion, the left ventricle is enlarged, the right ventricle is enlarged. The correct answer is left ventricular enlargement. This is the false statement. In the PA view, we can appreciate an enlarged left atrium causing displacement of the left atrial appendage outward and causing straightening of the left cardiac border as indicated by the red arrow. We can see a double density consisting of overlapping of the left atrium as indicated by the black arrow and right atrium as indicated by the white arrow. We can see also evidence of hilar congestion. We can see that the left main bronchus is elevated by the enlarged left atrium, pushing it upwards as indicated by the blue arrow. In the lateral X-ray, we can see the barium-filled esophagus indented by the enlarged left atrium. We can see evidence of mitral valve calcification. We can see also evidence of right ventricular enlargement as indicated by obliteration of the retrosternal space. Another question: which one of the following ECGs cannot be the presenting ECG for a patient with isolated mitral stenosis? This is ECG number 1, this is ECG number 2, this is ECG number 3, this is ECG number 4, The correct answer is ECG number 3 because this ECG cannot be the presenting ECG for a patient with isolated mitral stenosis because this ECG shows evidence of left ventricular hypertrophy which does not occur in mitral stenosis. We can see a very deep S wave in V1 and a very tall R wave in V5, and one of the voltage criteria for left ventricular hypertrophy consists of an S wave in V1 plus an R wave in V5 or V6 more than 35 mm, which is the case in this ECG. What about the other ECGs? ECG number 1 shows evidence of left atrial enlargement and right ventricular hypertrophy. Both can occur in mitral stenosis. Left atrial enlargement is detected in this ECG by a predominantly negative terminal portion of the biphasic P wave in V1. P wave can normally be biphasic in V1, but only in left atrial enlargement will the terminal portion be prominent and widely negative in V1 in the presence of left atrial enlargement. Again, in DCG, we can see evidence of right atrial enlargement by this tall P wave or P pulmonale, which is more than 2.5 millimeter in amplitude. There is also evidence of right ventricular hypertrophy as evidenced by tall R wave in V1. Normally, the ratio between the R wave and the S wave in V1 is less than 1. In the presence of right ventricular hypertrophy, the ratio between the R wave and the S wave in V1 is equal to or more than 1. In the lower part of the slide, this diagram shows the different criteria of atrial enlargement. Right atrial enlargement, or P pulmonale, can be detected by a tall P wave more than 2.5 mm in lead 2, while left atrial enlargement can be detected by P mitral or notched P wave in lead 2 equal to or more than 120 millisecond in duration. In lead V1, the terminal portion of the biphasic P wave in V1 is deep and widely negative. Criteria of right ventricular hypertrophy include right axis deviation or indeterminate axis, right atrial enlargement, which often accompanies right ventricular hypertrophy, incomplete right bundle branch block or an RSR- in lead V1, low voltage, especially with emphysema, persistent precordial S waves from V1 to V6, strain in right ventricular leads, and finally tall R wave in lead V1. ECG number 2 shows evidence of atrial fibrillation, which again can occur in mitral stenosis patients. The ECG shows absent P waves, very irregular rhythm, and you can appreciate in V1 this very irregular rhythm with very variable cycle lengths. Some of the cycle lengths are double the length of other cycle lengths, as well as fibrillatory waves clearly seen in V1. ECG number 4 is totally normal. The ECG shows sinus rhythm with a P wave preceding each QRS complex. The heart rate is around 70 beats per minute. The axis is normal, around 0 degrees, and there is no evidence of any chamber enlargement. A normal ECG can be detected in patients with mild mitral stenosis. Now, what about the role of echocardiography in evaluation of the mitral valve in patients with mitral stenosis? Echocardiography can evaluate the mitral valve both structurally and functionally. Figure A shows an apical 4-chamber view, and in this view we can see the increased thickness of both the anterior and mitral valve leaflets. In figure B, this is a parasternal long axis view showing diastolic doming of the anterior and the posterior mitral valve leaflets. Figure C shows a parasternal short axis view at the level of the mitral valve, and the fish mouth appearance of the stenotic mitral valve can be seen in this view. Figure D shows a continuous wave mitral flow Doppler consisting of an early rapid early filling or E wave and a late atrial contraction wave. The deceleration slope of the initial E wave is used to determine the severity of mitral valve stenosis. The steeper this deceleration slope, the less severe is mitral valve stenosis, and vice versa. Continuous wave mitral valve Doppler flow is also used to measure mean and peak pressure gradient across the mitral valve. Figure E shows continuous wave Doppler flow across the tricuspid valve, showing significant tricuspid regurg as a result of severe pulmonary hypertension. Figure F shows again a parasternal short axis view at the level of the mitral valve. The borders of the mitral valve are traced manually, and the machine, estimates the area of the valve orifice, and so we can obtain the mitral valve orifice area by the planimetry method. This is a catheter simultaneous recording of the pulmonary capillary wedge pressure, which reflects left atrial pressure and left ventricular diastolic pressure. The pulmonary capillary wedge pressure is very high, and so there is a very significant diastolic gradient between the left atrium and the left ventricle. Another question: all of the following is recommended as medical management line for patients with mitral stenosis except salt restriction, loop diuretics, heart rate controlling agents, oral anticoagulation in presence of atrial fibrillation or previous history of embolization, long-acting penicillin, and finally afterload reducing agents as ACE inhibitors or angiotensin receptor blockers. The correct answer is afterload reducing agents as ACE inhibitors or angiotensin receptor blockers. This is the false statement. Afterload reducing agents are used in the presence of impaired left ventricular function. Salt restriction and loop diuretics are used in mitral stenosis patients to reduce symptoms of pulmonary or systemic congestion. Heart rate controlling agents are used to reduce heart rate, so prolong diastolic periods, so allowing more diastolic flow across the mitral valve, which is stenotic, and so reducing the diastolic gradient across the mitral valve between the left atrium and the left ventricle. Since patients with mitral stenosis and atrial fibrillation or previous history of embolization have a very high risk of thromboembolic events, any patient with mitral stenosis and AF or previous embolization should receive lifelong anticoagulation. Because rheumatic fever is responsible for the vast majority of cases of mitral stenosis, long-acting penicillin should be lifelong secondary prevention measure for rheumatic fever in these cases. A new question: what is the best treatment option for a patient with symptomatic severe, pliable, isolated mitral stenosis? Diuretics and rate controlling agents, balloon mitral valvuloplasty, mitral valve repair, closed mitral valvotomy, or mitral valve replacement. The correct answer is balloon mitral valvuloplasty. Since the patient has severe mitral stenosis and is still symptomatic despite medical treatment, so balloon mitral valvuloplasty is the best treatment option. Balloon mitral valvuloplasty gives better results than closed mitral valvotomy. Mitral valve repair is used in patients having severe mitral regurg. Mitral valve replacement is only an option when there is a contraindication for balloon mitral valvuloplasty in patients with mitral stenosis. Another question, all of the following are contraindications for balloon mitral valvuloplasty in patients with mitral stenosis except the presence of a left atrial thrombus, the presence of mild mitral regurg, the presence of moderate or severe mitral regurg, the presence of markedly thickened calcified immobile leaflets with calcified commissures, associated severe aortic regurg or stenosis. Correct answer is mild mitral regurg. Obviously, we cannot advance the balloon valvuloplasty catheter through the left atrium in the presence of a thrombus for fear of dislodging this thrombus and causing a thromboembolic event, stroke or acute lower limb ischemia. In patients having more than mitral regurg, we cannot again use the balloon mitral valvuloplasty for fear of aggravating the degree of mitral regurg. Again, if the valve shows markedly thickened, calcified immobile leaflets with calcified commissures, we cannot use the balloon mitral valvuloplasty in this case, because the idea of using this balloon is to split the fused commissures. If the commissures are very calcified, not only the balloon valvuloplasty will fail to split these very calcified commissures, but also may induce significant mitral regurg. Finally, if the patient has a significant pathology affecting the aortic valve, for example, severe aortic regurg or stenosis, and he will eventually be subjected to open heart surgery to treat the aortic valve, so no need to subject him to a balloon valvuloplasty for the mitral valve. Anyway, he is going to be subjected to open heart surgery to repair and or replace the mitral and the aortic valves in the same setting. So what are the indications of balloon mitral valvuloplasty? The indications consist of symptomatic significant mitral stenosis, mitral valve area less than 1.5 cm square, significant mitral stenosis with evidence of pulmonary hypertension or no onset atrial fibrillation. Precautions: the valve should have a suitable morphology. A very calcified immobile valve, especially with calcified commissures, are not suitable for balloon mitral valvuloplasty. The presence of left atrial or left atrial appendage thrombus is another contraindication for balloon mitral valvuloplasty. Finally, more than mild mitral regurg is a contraindication for balloon mitral valvuloplasty, as I have explained before. Now, what are the indications for surgical management? Indications of surgical management include the presence of concomitant significant mitral regurg, which is a contraindication for balloon mitral valvuloplasty, the presence of other significant valve lesion requiring open heart surgery, like a significant tricuspid regurg or significant aortic regurg or aortic stenosis, the presence of a large left atrial thrombus or left atrial appendage thrombus necessitating surgical removal of this thrombus, a valve morphology not suitable for balloon mitral valvuloplasty, like the presence of significant calcified commissures. Types of surgical management include either open mitral commissurotomy or mitral valve replacement if the valve morphology is not suitable for commissurotomy. This diagram shows how the balloon catheter is advanced through the right atrium Then through a transseptum puncture, it passes across the interatrial septum into the left atrium and then across the mitral valve. The balloon is inflated to dilate the valve by splitting the fused commissures of the stenotic valve. A successful balloon valvuloplasty is defined as a valvular area more than 1.5 cm square with mitral regurg less than grade 2.